time, as you recall, we kind of created a framework through which we typically examine the value of care provided by a provider, organization, or network. And this week we're going to dig deeper into some of the real challenges that providers, particularly safety net providers, are facing as they explore value-based purchasing models from a financial forecasting standpoint. I think you know the three of us, and all three of us are on the phone with you this morning, and you will have some opportunities to interact with us over the course of the next coming weeks, more on a one-on-one basis as we prepare for the final session of this collaborative. After this, there are 3 remaining sessions. Session 4 will cover the last of the financial skill areas, and then session 5 will delve into a case study where we'll be asking you folks to interact with us as we discuss some of the challenges that we see in various value-based payment methodologies. And then the last session on December 5th, we will be going for a little bit longer. We'll be going for 2 hours. And this is an opportunity, now that we've been with each other for about 12 weeks, to kind of reflect on where you are and how to put some of this information into action. Today's discussion, we're going to start by taking a look at the homework that you folks submitted and having a bit of a discussion around some of your existing capabilities for addressing value-based payment change. And then we're going to talk, as I mentioned, we're going to talk about some of the real fundamental challenges we have in evaluating new payment models. I'm also going to introduce a final assignment. We really want to keep this lightweight. Our goal is not to create additional work for you folks, but really to get you thinking about how to apply this information in your current environment and setting. And then we have a couple of more questions. I hope you found the homework to be not particularly burdensome, but really an opportunity to just kind of put some of your thoughts down on how this information is impacting you today. In terms of the week 2 homework, we essentially asked you to comment on your ability to address key areas in the value equation in order to be financially successful under new and emerging payment models. So we asked about your ability to track outcome measures for populations of patients that are attributed to you by payers, and how, whether or not you've evaluated ways of doing more with less, essentially through alternative touches. As you can see here, and not particularly surprising, most organizations have indicated some capability or capacity to track outcome measures. All but one that responded, in fact, indicated that they had some ability to do so, although several of the groups indicated that their ability was somewhat limited, either because they were still reliant heavily on kind of the manual passing back and forth of data through Excel spreadsheets, or because they weren't able to do the full breadth of outcome measurement that they believe their payers would be expecting of them. In terms of readiness to use some form of alternative touch to reach patients, the group was a little more split, with some indicating that they've implemented fairly robust telehealth capabilities to interact with patients even when they aren't physically in their building, some using home monitoring in relatively limited pilots, some using chronic disease management prompts and reminders via text message, and others using telephonic follow-up post-discharge from the hospital. But others had indicated that they were either considering this type of capability or had very limited telephonic follow-up capacity, and some indicating they had none of this type of approach. I'll pause for a second. I want to see if folks had questions or wanted to make any comments about their responses in terms of their readiness in these areas. Okay, I'll keep us moving then. The next set of questions revolved around cost and utilization and asked you to indicate whether your organization had the ability to receive cost and utilization data from at least one payer. And as you can see, it was a perfect split amongst the 10 respondents, which frankly, from our standpoint, was actually a pretty good thing. Again, this is an area where safety net providers have traditionally struggled to garner, I think, the interest of plans in sharing this type of data. So the fact that 50% of you have it certainly speaks well to your readiness. We did hear, however, that one of the challenges that they're experiencing was that the plans are not willing to share this until they're already in value-based purchasing arrangements. And one of the things we'll discuss today is how that really presents a challenge in terms of forecasting or evaluating the potential of a contract is not having good historical data. So perhaps we can spend some time today talking about strategies that others have employed to actually get this information ahead of being asked to sign value-based contracts. In the area of risk adjustment and specifically around care coordination or clinical pathways tied to risk scores, you can see that this is an area where the group has not made much inroads or not seen necessarily as important to their strategy, with 6 indicating they had no ability to do this, 3 indicating a limited ability to do this, and only 1 feeling as if they had the full scale of capability. When we talk about budgeting later in this collaborative, this becomes kind of a critical question because the ability to apply risk scores or some type of indication of risk level to a patient is often used to then size the number of patients on a given care coordinator, navigator, or other type of physician extenders panel. And certainly, there's a large percentage of the population that may not benefit from any care coordination, and then some patients that benefit from fairly intense care coordination or population health, whatever you want to refer to that role as. And from a budgeting standpoint and team planning standpoint, this risk adjustment is fairly critical. So we'll talk a little bit about that, I think, the next session. And then the last question asked for a plan to increase access to patients and to meet the needs of all populations. And in this area, virtually everyone indicated that they had some desire to expand, although some felt they were moving further ahead than others. Others indicated that this was something they were evaluating. And this is not uncommon. We've seen this in just about every market we've worked in. The value-based reimbursement and value-based purchasing often tied to either a Medicaid expansion or the expansion of managed care in a given geography really has created kind of an opportunity for growth for much of the safety net. And certainly access is seen as one of the key drivers of success under these types of models, and therefore kind of a top priority for organizations. Before we move into today's content, is there anything anyone would like to share, any questions that folks have as they thought through the homework from last week? Okay, well, we'll just keep moving. Today we're going to talk about forecasting, and in a future session we're going to talk about how to manage against the financial forecast. But there's obviously a great bit of interdependency between these two concepts, and they're inherently linked. And what we're hoping to answer from a financial standpoint is, does a value-based payment methodology change our revenue in a positive direction such that it is greater than the increase in our operating costs and our amortized capital costs? So we're going to have to make some capital investments. We're going to have to increase our operating budgets because we're going to have new roles, new capacities, new technologies in place. And the hope is that our increase in revenue associated with that will essentially be a net positive. Forecasting, which we'll talk about today, indicates how well, it's a projection of how financially well we have to do under a model essentially to come out ahead. And when we talk about managing to a value-based methodology from a financial standpoint, it's really about having the controls in place to ensure that we're trending in the right direction to achieve what we had forecasted initially. So without further ado, we are going to talk about forecasting under value-based reimbursement methodologies. I'm going to stop here, and if I don't get any responses, I will start calling on folks, because I think it's important that we talk a little bit about how you forecast today. When you're going into a new year and you're putting together a budget and attempting to forecast revenue, what are the most important drivers of that budget, and how do you begin to put down on paper the anticipated volume as well as anticipated revenue that you anticipate or that you expect?
It's David Emroff, now in FQHC, and some simple things are just we look at the past year, how we did, and what kind of growth we can expect for the future years.
Yeah. So certainly, kind of historical trends, just historical volume, your existing patient base, those are all important. Is there seasonality to that? Do you find that given quarters, given months, there tends to be kind of micro trends, or is it fairly consistent throughout the year?
Oh yeah, definitely. It changes all throughout the year, and a budget or projected, we're an outpatient facility, so projected visits in July and August will be significantly lower than it'll be in the fall, when kids are going back to school and things. So, we do that, and then also look at new programs and new things we're bringing on for the following year to project as well. Yeah,
and as an FQHC, is it fairly simple? I don't want to oversimplify it or indicate that there aren't challenges, but based on volume, then to project revenue, I assume.
For us, what's been changing is, as our payer mix changes, things can get a little out of whack, and then also as providers come and go, those are the two things that'll tweak our revenue significantly. But for the most part, we have we know we have estimates of what a provider will see per hour. We put that into a model. That's, kind of consistent.
Yeah, okay, great. Any other thoughts from any other groups?
No, this is Josephine from Merson. We do a similar. We look historically, and payer mix plays a big part of how we do things. And if we're getting on new sites, so we anticipate in closing new sites, that all has a factor as well.
Okay. So from what I'm hearing, the challenges really revolve around things like changes in the underlying payer mix, changes in providers coming and going, with new sites opening and closing, and there's some seasonality to it. But the historical trends have been a kind of a key to essentially evaluating performance. And what we'll be discussing today is historical trends actually are an important factor as we go forward, but a lot changes under these new types of models. We refer to this challenge, the challenge that you all face, as the ACO conundrum. What we mean by that is organizations see this opportunity, and in particular, and we will be using some ACO contract models today to have this conversation. They look at this as clearly an opportunity for earned incentives above and beyond maybe what they've paid historically, but it's fundamentally challenging to understand just what it's going to take to execute against these contracts in order to achieve those goals. And the ACO conundrum is probably best paraphrased as saying that since you are most likely in value-based models competing against your past self, it behooves you to do something fundamentally different going forward to address the cost and outcome needs of a given population. I'm going to just kind of restate that by saying if a program is self-benchmarking, and most of the value-based payment models that you will see will have some element of self-benchmarking, that means that it looks at the historical costs and the historical outcomes for a population of patients that you've already seen or been seeing. And so you must fundamentally change what you're doing to improve in key areas. And therein lies the problem, because if you have to change, that you typically requires new investments, both capital investments and potentially changes in your operating budgets, and with no necessary guarantee of how that's going to manifest itself as additional revenue on your bottom line. These are the kind of 6 key fundamental questions that we use when we start breaking down a payment methodology and evaluating a payment methodology. First is, does it have impact on our base payments? Second is, will there be any impact on associated volume? Third is, are there guaranteed infrastructure payments? Is there any part of the payment methodology that I can bank out of the gate, knowing in fact that I will receive that portion of the payments? The fourth is, does the payment methodology in and of itself prevent opportunities to expand my charge master? And we'll talk about what this means and where there are some opportunities for that to occur. The fifth is, are quality incentives involved or quality measures involved? How do they factor into the formula? And lastly, are there incentives at risk based on total cost of care for the population served? And we believe these 6 questions essentially articulate the kind of evolution and maturity of value-based reimbursement models going forward. And we'll talk about that in just a second. But if base payments are impacted either up or down, forecasting models become much more complex very quickly. If major shifts in volume are going to be resulted as a resulting factor of the new payment methodology, you have to look at things like loss of productivity in your forecasting models and determine if resulting upside essentially compensates for those losses in productivity. If there are guaranteed infrastructure payments, then this upside in revenue can create a temporary time period in which to prepare. And we'll talk about groups who have used payment models that have some guaranteed payments in them, really to build out their capability to be successful in the future. If there are options to expand the charge master, for example, the addition of new chronic care management codes added by CMS, you really need to take these into consideration when creating your forecast, because these are essentially offsetting codes for some of the new staff and some of the new capabilities your organization will need to develop. If quality incentives come into place, then your forecasting really needs to start with a baselining and understanding of your realistic ability to perform against the measures of a contract. So unlike some of your historical forecasting efforts, you have to almost immediately look at the clinical side of the house to determine whether, in fact, these are good financial decisions to enter into. And then, of course, most or many value-based models are driven off of some evaluation of total cost of care. And this really requires us for the first time to get our financial folks involved in understanding utilization of services, which by and large is a new skill. Not saying it's a completely new skill for everyone on this call, but by and large within the safety net is a relatively new skill. And is, as we'll discuss, really requires a kind of clinical and financial partnership to evaluate how to make this happen. You can take essentially any value-based payment methodology and hash it up against these 6 questions and start to draw some conclusions about how that payment methodology will impact you from a financial standpoint. And we'll talk about this in today's conversation. The other challenge we see in new payments models and this is one that is particularly impactful on safety net providers, is the difference between direct financial downside risk and indirect financial downside risk. And I'm going to kind of define these for you as we go forward. Direct financial downside is when, in fact, the payment methodology has the potential to pay you less than previous payment methodologies for the same services, but based on your performance against a set of indicators. Terms we would use for direct financial downside risk would include the term withholds, where a certain percentage of your contracted payment rate were withheld unless you received unless you achieved a certain level of performance in the model. Some of you, and we're not going to get into great detail on MACRA and the new MIPS payment model under Medicare, but some of you may be exposed to MIPS, and MIPS has a withhold of up to 9% of your contracted rate with Medicare if you underperform on certain quality measures. So that would be what we would consider a direct financial downside risk. Another term or another kind of downside risk would be a two-sided shared savings model, a model in which an organization may receive a portion of savings generated, but is required to pay back a portion of losses generated if they had cost overruns. And many times, safety net providers, particularly those first exploring value-based reimbursements, will want to avoid direct financial downside risks really at all costs. It brings a whole new set of challenges, not just to forecasting, but management and budgeting of these types of initiatives, and has the potential to even create true financial insolvency for organizations should they greatly overrun the contracted payment methodology and end up owing money at the end of the year. Indirect financial downside risk, however, is also concerning, and this is when, even though the value-based reimbursement methodology has appropriate protections in place to ensure that you are paid no less than you would have been previously, the changes in how you need to organize yourself cause you to essentially lose money by either reducing volume or over-investing in and subsequently underperforming against a given contract. And I'm going to go back for a second. I want to go back to our ACO conundrum slide and say that it is very commonly, this is probably the most common estimate we hear, and a lot of experts have said that this is right in kind of the ballpark, and it's been consistent with our experience, that organizations that form an ACO will spend about $2.5 million to administer or run that ACO over a 3-year period. Some people say it's closer to $1 million. Some people say it's closer to $4 million. But the idea is that there's real money that goes into creating the types of responses that folks feel are necessary to make these types of payment models work. And the indirect financial risk says, even if a contract protects us from true downside, there's a lot at stake here. And as safety net providers, we are typically even a little further behind our non-safety net peers because we don't necessarily have large capital reserves to draw on to make these investments, to make this leap forward into the value-based purchasing world. You'll recall that in our very first homework assignment, we asked you to reflect on what concerned you about the value-based reimbursement world. And one of the things we asked you to rank was just a sheer inability to make the investments necessary to make this transition. And that's a very real concern, and it's one that we'll talk a little bit about today. I'll move through this reasonably quickly, but I think this underlies kind of the challenge or the change, essentially, in the work associated with forecasting under new payment models. If you're operating in 100% fee-for-service model, your financial challenges really revolve around keeping your cost per service below your reimbursement across all payer mixes and driving adequate volume through the care model to offset your overhead. So you acknowledged in our brief conversation that you really do need to have adequate follow-up in order for essentially in order to cover your costs, and that can fluctuate seasonally. We've talked a little bit about transitional models that don't necessarily qualify as true value-based reimbursement models, but start to move us in the direction of the type of infrastructure that we need in order to operate under most value-based reimbursement models. And these infrastructure-based payments, sometimes referred to as a care coordination fee, sometimes referred to as a patient-centered medical home fee, are essentially guaranteed payments for a very specific set of services that you're going to use to drive performance in certain areas. In some states, the Medicaid agency in your state has created a medical home payment model that typically pays a per member per month to an organization that has appropriate care coordination staff to address the unique needs of that population. And although there may be some reporting requirements on the progress that those patients are making, those payments are usually guaranteed. And so that's nice. It gives us an opportunity to earn a little bit more money. Maybe it's not 10%, but we're illustrative. We're just using this as an illustration. And the forecasting challenge really is still relatively simple. Is the additional expectations placed on me something that I can pay for within the new revenue that I will receive? But the more important questions to be asking are, what will be expected of me in the future? At what point will they start to tie these types of payments to very specific outcomes and measures? And frankly, how long can this last? The overarching goal of health reform is to reduce costs, not increase costs. And as such, this is truly a transitional model. And then we move into the kind of classic pay-for-performance models. These are the upside-only rewards for achieving certain clinical or other population health goals. And unlike the infrastructure payments, these payments are typically not guaranteed. And as a result, you have to begin operating in an environment or in a mode where you've got to budget and pay for these services and not necessarily know if you're going to reap those rewards. So the question becomes, and we're going to talk about budgeting in next week's or in the session 2 weeks from now. But how do you budget for these programs that are necessary to achieve these outcomes? And what's going to happen to you if you fail to meet those incentives and those added costs have a significant negative impact on your organization? And ultimately, where we feel very strongly that value-based reimbursements intend to go is some kind of straddling of our historical reimbursement, where if we do better than necessary, that we achieve financial upside that could be even more significant. But if we do worse, then we will see a decrease in our total revenue. And this is not inconsequential, folks. This is intentional on the part of the designers of various value-based reimbursement systems because they are intending to drive more volume to those organizations that can be successful. So they're giving them the resources to grow and, frankly, to kind of weed out and almost start to move towards either consolidation or elimination of those that can't because they won't have the resources essentially to maintain their operations. Challenges you'll see here are how do I bear losses if I don't earn incentives, and will cash flow, even just cash flow consequences of this, if I'm going to start to get paid less on a per unit basis, will those alone create financial instability for me? There is a question, do we have a formula that is used to calculate the total cost of care? Are people using different methods to calculate it? The answer to both is yes. In fact, we're going to spend a lot of time with total cost of care today, so I'm going to hold off on that. But what I will say is we're going to use kind of an example, and that all programs that factor total cost of care are evaluated differently, and that's something that you need to be extremely cautious about understanding. You want to understand precisely which costs you are and aren't going to be held accountable for in that. So we're going to talk about one particular example of how it's being calculated in a longstanding value-based reimbursement program, but we can speak to some of the modifications or changes in those types of programs. And here we go. Cost of care or total cost of care is, essentially one of the leading drivers of most value-based reimbursements. We'll talk about the more basic models that don't factor in total cost of care, but many models include cost of care somehow in their formulation. And it's really defined as the sum of all payments made by a payer for a given patient or population for a given time for a defined set of services. So the total cost of care is typically associated with every single claim paid for every single patient within an attributed population. And, likely, depending on the payer and depending on their financial arrangements, likely includes professional, facility, drug, and durable medical good expenses. In fact, I'm going to show you a slide from CMS that is used in their definition of total cost of care that breaks the total cost of care down by roughly 50 categories. It may even be more than that, and we'll look at that in a second. But if you recall, when we spoke about our value equation and using that to discuss relative value of the care that you deliver, we referred to the term cost of us, which was everything that was spent on our organization by that plan, and the cost of them, which is everything that was spent everywhere else. And it is those two things that added together really define the total cost of care. We're going to talk about how total cost of care is used in value-based payment methodologies. We're going to talk about strategies to reduce both the cost of us and the cost of them, although we're going to largely focus on identifying what we consider to be unnecessary or unvaluable utilization that ultimately leads to increased costs in the system. Here's that slide I was talking about, and it's probably a little bit small on your screen to read some of the detail, but there's a lot of interesting information here. This is directly out of the definition of total cost of care for the Medicare Shared Savings Program, also known as the ACO program, and it explains how for each beneficiary of Medicare, on average, just under $1,200 per month are spent across a large variety of services. If you look just at the major pie pieces, you can see that there are almost about $365 per beneficiary per month on average spent on inpatient care, $251 on professional fees, that's all physician services, $231 on prescription drugs, $138 on various outpatient procedures, including dialysis, imaging, therapy, and other outpatient procedures, $81 per beneficiary per month on skilled nursing, $58 on home health, $29 on durable medical equipment, and $30 on hospice. But then when you look within some of those major pie pieces, you'll see that they're made up of a variety of different services. So professional fees break down into office visits, other evaluative services, other procedures, the professional side cost of any other procedures delivered by physicians, imaging done in the physician office setting, labs, etc. The inpatient breakout to inpatient medical and inpatient surgical charges, and then into a couple of other very small buckets. But the important thing to understand is that when CMS talks about total cost of care, they're referring to every CPT code or DRG code that fits within these pie pieces as being the total cost of care. And you can calculate total cost of care for an individual. You can calculate total cost of care for a population. And we'll talk a little bit about how they calculate total cost of care for a population in this regard. But just very simply, an oversimplification, but certainly one that I think will help us wrap our heads around this, is that this pie represents all patients on Medicare, fee-for-service Medicare in the country, if they added up every single payment amount associated with the service areas that you see on this pie chart. And understanding, regardless of who the payer is, how they define the services that go into their pie chart is critical. In most cases, it's literally everything they pay for. And in most cases in Medicaid, that's dictated by the state and the contracts that they hold with the state. What does this tell us in terms of what our opportunity is? Well, it tells us that we have a lot of different areas to look for potential to reduce total cost of care as we do our forecasting under value-based reimbursement methodologies that include an element of total cost of care. So we're going to talk about a specific payment model. And in this payment model, we're going to assume that it keeps base payments to all providers in the ecosystem exactly the same. So in terms of forecasting, we don't have to go through the additional exercise of looking at true downside against the services that we get paid for on a fee-for-service basis. The provider is eligible to receive up to 50% of generated shared savings, provided a set of quality measures were achieved or attained. And the payment model gave prepayments of shared savings totaling $250,000, a one-time payment of $250,000, $36 per attributed member on a one-time basis, and then $8 per member per month for the first 24 months. This is the Medicare ACO investment model, not currently available, potentially someday will be available, but it's a valuable lens through which we can explore this issue of financial forecasting under new payment models, and I'll explain why we're using it even though it's not currently available. First, it has each of the elements of our value equation, and it involves total cost of care with a desire to increase for that provider the amount of money spent with them, but decreasing the amount of money spent elsewhere. It does require performance against a set of outcome measures, so you're not off the hook for quality improvement in specific areas under this payment methodology. It includes risk adjustment and requires scale in terms of having a minimum number of attributed patients. And virtually all providers are currently eligible for it today, although, as I mentioned, the investment model itself, which is the prepayment, is not available. This is the Medicare Shared Savings Program, and I think with the exception of one or two of you on the phone, this would be something that you would be eligible for. It's the most widely used model and the most widely studied model, and it is very common that it's copied for state-level models within Medicaid programs. And once we kind of study how it works, because it's got every single one of those elements, we can then take it and then look at different programs and how it impacts our ability to forecast and our forecasting approach. So it's pretty flexible in that regard, even though it's a Medicare model, and we know that most of you are dealing primarily or likely primarily in Medicaid, even though it's not something you can currently enter today. It really is a good lens through which to study this type of work. When considering a model like this and our ability to forecast against it, the number one or the first consideration is attribution. As I mentioned earlier, in order to calculate something like total cost of care, you need to be referring to a specific population of patients, an attributed population. In this model, it's usually based on, and in this model it is no exception, proving a historical relationship with the patient, usually over a multi-year period of time, and always via paid claims. Because at the end of the day, that's the only data source that a payer will have to build one of these value-based payment models. What you see here, this is actual data from an actual organization that entered this program that indicates the assigned beneficiaries across a 3-year benchmark. They call them benchmark years, which are the previous 3 years. And you see that the number grows, 5245, 5668, and 5987. What that means is that benchmark year 3 would be last year, benchmark year 2 would be the year before, and benchmark year 1 would be 3 years ago or 2 years prior. And that means that roughly 6,000 patients were attributed to this provider organization last year. Of those 6,000, 5668 of them were also attributed in the year before, and only 5,245 of them were attributed in the year 2 years prior. Why do they have a 3-year historical attribution in this model? Because they are self-benchmarking this program, and they want to look at costs for the previous 3 years for these precise patients. I kind of opened by saying that many of these programs are self-benchmarking and really require us to look at doing something different, because these are the same patients that we've been seeing for 3 years. And when we look at the costs of these patients, we are looking at costs that in this program they believe that we are on the hook for. By the way, attribution is something that has tripped up a lot of safety net providers who have adopted value-based purchase. I apologize, the slides did not look off in PowerPoint, but I apologize that some of that word is cut off there. It's tripped up a lot of safety net providers who have adopted value-based purchases early on, because as they made their forecasts, they expected that any patient that they had seen with a given insurance would be attributed to them, when in fact, in a model like this, it's much more complicated than that. They needed to be kind of the provider of record, meaning they had the most charges for that patient as compared to other providers, and they needed to have seen that patient for 3 years. So they could have had roughly 700 more patients in this model if they had seen them also in the 2 preceding years. The second consideration is risk-adjusted cost. And what you're seeing here is, based on that very same example, a breakout into 4 major Medicaid beneficiary areas: end-stage renal disease, which is commonly referred to as dialysis; the disabled population, who are all patients whose reason for Medicare eligibility is a disability; the aged dual population, which is the patients over 65 years of age who also qualify for Medicaid, and this is showing the Medicare-only spending on the dual population; and the aged non-dual population. This is what you pretty much refer to as your traditional Medicare population. It's patients over 65 who are not also dually eligible. Now, keep in mind, in a private physician office or a private hospital setting, the aged non-dual might make up an overwhelmingly large percentage of this population. But in a safety net provider, it's not uncommon for the aged dual or disabled population actually to make up a significant portion of the population. Now what you're seeing is, for those same benchmark years, the actual cost average on per patient average within these 4 buckets. There's a lot of interesting information here. First and foremost, you can see that in virtually all categories for this particular organization, that costs rose over the 3-year period. End-stage renal disease starting at about $68,000 and ending at about $73,500. And the age dual population starting at $9,000 and ending at $96,220. The age non-dual population actually shrunk ever so slightly by about $300. Another interesting piece of information is that this organization seems to be overperforming against national averages in most categories. In fact, it's only the end-stage renal disease population where they exceed the national average in 2013, and not by a significant margin. So this information is then used, it's kind of weighted and then reblended based on the makeup of the population. So if they have 10 end-stage renal disease patients and 90 disabled patients, they're going to take the weighted average of those two to get to their cost benchmarks. But it was important to establish a cost benchmark using some level of risk adjustment. So the long and the short of it is that for the roughly 6,000 patients with an average of about 8,000 in annual expenditures, which is that blended average, this organization ended up with a resulted or projected cost of $48,162,940.65, to which there is a minimum savings rate applied. What is a minimum savings rate? It's a mechanism for determining the actuarial soundness of the impact of the provider on cost. It is an attempt to reduce statistical variation year to year in cost as the reason why costs might go down. But that's a big challenge in forecasting under these models, is you have to start by saving 3.5% in this scenario before you accrue any additional shared savings to your organization. So in essence, the actual target for this organization is anything below $46,477,000 before they start accruing towards their value-based reimbursement model. If that wasn't enough, quality also factors into the equation. There's a composite score assigned to the organization based on 33 measures. Many of them would be familiar to you because they're drawn from UDS. Some would be not as familiar to you, and some of them really tap into things like patient satisfaction or patient access. And on average, we use 2014 data here. On average, the quality score achieved by all ACOs operating under this value-based payment methodology was 83%. And what that means is that the average ACO only took home 41.5 cents of each dollar it saved because the organization had the option to receive half of what they saved. That gets multiplied by the 83% score. So that results in 41.5 cents of each dollar saved once they've hit that minimum savings rate. So a lot of tee up here to start to look at how this works. But a couple of notes, because quality has not historically been something that impacted greatly our reimbursement, and here it is with the potential to have a significant impact on our reimbursement. And so we wanted to give you a couple of important considerations as you start to think about how to project what your take-home might be under a model like this. First, determine how measures are calculated and or reported. Are they claims-based or are they self-reported? This is critical. We've seen a lot of organizations far exceed their performance targets based on their EHR data, far underperform against the data that the payer has, and leave a lot of money on the table. They correctly forecast what they thought they were going to be eligible for and then lost a significant portion of it because the plan did not have the same record keeping that they did. And to be realistic in your forecasting, we think it's important that you have a baseline for each of the quality measures that are included in your contract. This goes for the most basic of pay for performance to the most sophisticated of financial, dual-sided financial risk models that you might experience under value-based reimbursement contracts. And so the time to engage your clinical leadership and quality improvement teams in the forecasting effort is as soon as possible with historical data before signing up for these types of arrangements. So the question that I'm sure you're probably at least thinking in the back of your minds is, he told us we have to save 3.5% before we see a dime, and what is realistic to assume in terms of potential savings. What I've done here is I've plotted the results from approximately 350 accountable care organizations. This is their 2014 results. 2015 is not yet publicly available, but I expect it should be soon. And there's some very interesting information here. First, you see that the line crosses the y-axis at about 150 out of, I think it's 338 ACOs. That means that slightly more than half of the organizations generated shared savings. The other 150, those to the left of the intersection point there, failed to generate shared savings. In fact, most of them generating fairly significant cost overruns. You can also see from this graph that there's a pretty clear set of outliers. Right at about 300 on the x-axis, you can see that the line takes a pretty sharp upward slant. I suspect that all of these should be considered extreme outliers and not really factor into our thinking about what is possible under these models. Same thing around about 15 or 20 on the x-axis. You see that sharp downturn that looks like about 5%, maybe about 7%. So that tells us that most organizations that operated under this payment model either lost 7% or saved somewhere around 7 or 8%. That gives us some sense of what's realistic under these models. Question is that we've received is, how many of these included FQHCs with typical lower costs? And I'm going to comment on that in a couple of ways. First of all, I don't have the data to indicate which included FQHCs or not, but I certainly could go and look at which ones were made up predominantly of FQHCs just from knowing who those organizations are. So maybe we can take that as a homework assignment to look at that. But the typically lower costs is an interesting question because as, again, I'll continue to repeat this, that most of these value-based programs don't benchmark you against averages, national averages, regional averages, et cetera. Most of them benchmark you against yourself historically. That does not have necessarily the impact that you think it might have. Each of them is already, is kind of working off of their existing baseline or benchmark. But I can get you that information. I can tell you a number of the FQHC-led or predominantly FQHC ACOs have generated some savings. Some of them considerable. Some of them barely enough to break even under this model. Roughly 50% of the organizations fall between 2% savings and 8% savings. So that gives us some additional clues about what's realistic under these types of models. But there's no guarantees here, folks. I think you're already well aware of that. That these trends and these numbers, and we're going to talk about how you manage this and kind of track towards success. There really is no way of knowing where you're going to shake out at the end. So how do you possibly forecast under this model? And we're going to scratch the surface on the three most common ways that organizations do this. The first is through making some realistic estimates based on whole population. The second is a targeted analysis of specific high-cost services and patients. And the third is with the use of actuarial support. And each has its pros and cons, which we'll discuss in a second. We have a pretty hard recommendation for you. Most groups enter into these programs or these arrangements using kind of simple, realistic estimates of the savings of a whole population. And you can see that here. All I've done is taken that $48 million baseline, the $46 million target after the minimum savings rate, and then identified what the various savings levels would achieve in terms of annual payout for each of at each of these percentage points. The green are probably in that realistic band that we said many organizations have fallen. The yellow starts to get into that, kind of pie in the sky, somewhat unrealistic band. And then the red really fall into the virtually impossible. We feel pretty strongly that 10% starts to approach a hypothetical wall. It's just hard to get beyond 10% in a given year in any one of these models. And you can see as a result of this that the math does not necessarily work extraordinarily well in these organizations' favor. At 41.5%, that's our 83% average score on the quality indicators. You have to get to a 6% year-over-year savings to generate about $440,000. And this is across about 7,000 patients. So it gives us some pause as we start to think about these models and how they might theoretically work or not work in our environment. A lot of effort goes into saving 6%. We're going to talk about in the budgeting module kind of what types of strategies are people using to generate those types of savings. And it gives us some pause in terms of just how hard it is to move the meter like this. It's also going to give us some thoughts and recommendations about how to proceed, going forward. A more successful approach is one in which we conduct some level of targeted analysis. And in this program, there's a pretty significant wealth of information provided to the organization upon their acceptance into the program. It includes key rates, typically per 1,000 of key variables. And I've just presented you here with some average discharges for various ambulatory sensitive conditions. There's literally 75 data points that you receive as you enter this program about your historical performance. This is just 5 of them that I think were of particular interest to this group. And what it shows is their per 1,000 patients, the number of discharges for these conditions that this population experienced historically. And I'm going to pick out, because it's one that we, it's one that we spend a lot of time with, all of us, that for diabetes, short-term complications of diabetes, the hospital utilization, which is emergency department and inpatient stay, that in 2015 they had 1.21 discharges per 1,000 beneficiaries, compared to a national average of 0.89 per 1,000 beneficiaries. So immediately we can start to do some much more realistic projection that also has a second benefit. So working through these various areas, we can start to identify common procedures that are driving costs and look for benchmarks to either national or state averages to start to get a sense of where we might want to focus our times and efforts. And the two advantages of this are, number one, it allows us to make some much more precise financial projections about areas we want to target. That's number one. But advantage number two is it actually starts to focus us in the areas that we need to focus in order to actually go about generating some savings. So it starts immediately, as we're evaluating the program, to start to develop that handoff between financial to clinical, to come back and say, okay, here's what I would need to do to drive down the readmission rate or the admission rate within our diabetes population. It's not necessarily realistic to say, well, let's just focus on getting to the national average next year, but this is kind of illustrative to say that if you were able to get closer to the national average, that you could actually start producing some of the savings necessary by relatively few interventions. And when we talk about managing these programs, we're going to talk about how important it is to have fewer, more impactful interventions because it's impossible to budget to try to change every single factor in the population that you're serving. So here's one example that could theoretically, again, it's probably not realistic to say we're just going to jump right to the national average, but we could play with these numbers and start to come up with plans and clinical strategies to get us to numbers where we could start to see some real potential for the savings that we would need to make this model work for us. So a good CFO and CMO or medical director partnership will need to go through this data, kind of line by line, making estimates and commitments to working towards improvement in these utilization areas, finding the things that the organization thinks it can impact, making realistic projections about the impact it could have, and then committing, in essence, to developing the programs or initiatives that are going to drive those budgets, which then in turn turns into your budget and planning activities, which we'll get to in a later session. Really, to do this very effectively, CMS is going to give you, in this model, and in most models, the payer is going to give you some aggregated or basic data, but really the gold standard is to use detailed claims data and fairly sophisticated analytics support to identify high-cost, high-frequency avoidable charges. And safety net organizations operating in models such as this one have found some interesting things out there that they could really impact. For example, a high utilization of emergency room visits for ear pain associated with ear infection, or use of medical beds when the medical bed was not indicated, but when a psychiatric bed was unavailable. These were things that they could systematically identify in the claims data, quantify the cost of, create an initiative around improving, and then demonstrate improvements, ultimately leading to savings against historical trends. The third and very common approach is to engage actuarial support. Unfortunately, this can be very expensive. Most actuarial models are held very closely, are considered proprietary, and you need to pay essentially to tap into them. The reason why actuarial support can be particularly useful is because they're essentially applying to this large claims data set kind of historical or institutional knowledge of what those kind of cost drivers are and which ones are and aren't able to be impacted. In order to get this kind of level of support, you can look to hire an actuarial firm. Managed care organizations typically have their own in-house models. There are some freestanding organizations that support providers in this. And in many cases, health systems are starting to develop this capability. So you would need to work with someone outside. We do not see a lot of safety net providers building actuarial teams within their organizations to address this. I just wanted to give you a sense from the American Medical Association, who's done some education on this topic. Actuaries can help to estimate the types and amounts of services that you'll be providing under a risk contract. They can help you independently evaluate cost and quality budgets, estimate potential risk exposure under contracts, allowing you to investigate whether you need to take other more advanced risk protection measures, determine likelihood that you'll be eligible to receive bonuses, and evaluate protection against unanticipated utilization that the various models will provide. So, helping determine if there's some anomalies in the data that might lead to unintended consequences. Let me just go back real quick and say, just as a reminder, actuarial support tends to be pretty expensive, even if you're sourcing it from a third party that knows how to do it. So it's an additional cost that you have to factor into this equation. And we think this really starts to make the case for why most safety net providers are going to have to be working with either other safety net providers to get some scale to really do this effectively or efficiently together, or with other partners in their community, whether that's managed care, whether that's larger health systems, non-safety net health systems. Okay, so I mentioned earlier in the model that there was an opportunity to receive guaranteed payments in the ACO investment model. And that changes the fundamental forecasting profile of this organization dramatically. The way in which the guaranteed payments would work is that they are a prepayment of shared savings that do not need to be repaid back if the organization does not achieve enough shared savings to do so. But it also ups essentially the threshold for which at which the organization would start to receive any shared savings. In our model, the organization, and this was a real organization, I want to just continue to point that out, a safety net-led group that entered this contract, they would have received about $1.8 million in guaranteed new revenue, roughly $600,000 a year, in a very, very low-risk investment in their infrastructure, which is roughly equivalent to generating, I think, about 6% if we went back and looked at that chart, year over year for the first 3 years, which is a typical contract period. They only pay the 8 PMPM for 24 months instead of 36 months. But this is something that we want to illustrate in terms of as you think about how to forecast against these models, is that this is a perfect example of where safety net providers are hampered by their ability to make these investments and should strongly consider value-based models that include some form of infrastructure payments. They're becoming increasingly rare. Medicare did not offer the ACO investment this year. We're not sure if they'll offer it again next year. We just don't know. But in your states, with your managed care partners, this is a fundamental game changer. The guaranteed payments took this from kind of a non-starter to a real opportunity for these organizations. Okay, so we've looked at a model that had no direct downside risk, no contracted downside risk, but some potential to overspend and underperform. Just talking quickly about some financial considerations when forecasting under two-sided models, which are those models that have direct downside risk first. It's virtually impossible to do that without actuarial support. So someone needs to be running historical claims data to determine if the contract presented is viable. That means you're already probably looking outside your organization for support in the forecasting process. In most cases, in two-sided risk models with true or direct downside risk, you will need to maintain financial reserves, and the contract will specify what those are. These can be significant. You may need to indicate an ability to cover the full or maximum loss under a particular contract. And that is where you may start to look at, and it's not a topic we're going to spend much time on in conversation in this session or in future sessions, but that's the point at which it may make sense to look at purchasing some external insurance against the value-based model that you're entering. That, once again, adds a new cost to your ability to do this kind of work, but may offer you some financial protections going forward. Before we have about 20 minutes left, I have to introduce both the homework and the team assignment. But I want to stop here. We've presented a lot of information. We're going to build upon this in the next session. And I just want to leave you with these three thoughts and then see if you folks have anything that you want to add to the conversation. Forecasting is challenging. Even just taking you through one example, granted a fairly comprehensive example, has taken us about 50 minutes. Scale is critical in these models. An organization with 15,000 patients is going to look a lot rosier or a lot more attainable than an organization with 7,000 patients. And for a variety of reasons, that minimum savings rate comes down, the ability to do certain things at scale goes up, and there really do start to be opportunities to kind of leverage those bigger numbers to get more done and generate a more rosy financial forecast. Value-based payment, entering into value-based payment arrangements requires considerable investment, oftentimes with little or no guarantee of repayment. So our guidance to safety net providers has long been, don't overlook models, even though they may feel a little uncomfortable, that offer any type of guaranteed support or transitional infrastructure support. Otherwise, you're really looking at scenarios where you're likely to have to operate or integrate with other potential partners. With that, I'm going to stop. I'm going to see if anyone wants to add anything, make any comments, or ask any questions, and then I'll talk a little bit about what happens next.
This is Chris in North Carolina. I've heard concerns raised that great, you can do and achieve savings in year one, but it gets harder and harder year 2, year 3, because you sort of got the low-hanging fruit in 1 and 2. And any thoughts on that?
Absolutely. Not only is that a potential concern, there's a formulaic way in which that actually happens, which is the previous year's cost accounts for, I think, something like 50% of the weighted baseline used to determine the next year's target. So if you cut 10% out of the budget the first year, probably not likely, but some organizations have done it, then that new cost gets the highest weighting in the next year. Shared savings, and we didn't mean to necessarily overemphasize shared savings. We wanted to show how each of the components of our value equation factor into models, but shared savings was obviously the vehicle we used to do that. Shared savings in and of itself is likely a transitional model because at some point you're going to max out your potential. Generally speaking, if you can cut 15% total out of a population over a number of years, there's not a lot left to cut. And so at that point, you'd probably already be transitioning into some type of bundle payment model, capitated payment model, something that was fundamentally different from what you had been doing for the previous 3 years. But yes, there is absolute truth to the fact that it does in fact get harder each year if you're successful. Other questions or comments? Okay. For next week, we've asked you to answer these 3 questions. Again, we're not trying to inundate you or overwhelm you with homework for homework's sake, but we think it helps enrich the conversation to have a little bit of information from you about how you're going about addressing some of these challenges. Within the survey link that you'll receive from AJ are 3 questions. We've asked you to come together as a team within your organization and just provide us with a little prose on how your organization is addressing these types of challenges. What tools would improve your ability to forecast financial outcomes of new payment methodologies? Do you have a group that oversees the clinical strategies that might help you achieve positive financial outcomes under these value-based payments? And how do you review outcomes for the populations that you serve? The true outcomes. We're going to talk next week about managing to certain outcomes. How are you reviewing those in terms of achievement of the outcomes that are going to tie to compensation within your organization? We talked about how some organizations do very basic forecasting, some do much more clinically focused forecasting, and then some outsource to an actuarial organization. If assuming that you really wanted to focus on the middle, that you didn't have the option to go outside, do you have that leadership group in place to do that work? And how are you going to review success against it? Again, not meant to overwhelm you with homework, really meant to keep you thinking about these challenges and help us next time we get together address some of your questions and concerns. For your final projects, and again, we do not want these to be overwhelming exercises. You're only going to have about 5 minutes to present on the last session, but we are asking you to go back to our second session last time we got together, and we talked about the value equation. We talked about the importance of having strategies within each of these areas for how you intend to make yourself more valuable in the contract that you sign, so that you achieve financial success under value-based reimbursement. So what we'd like you to think about is the value platform that your organization can bring to the table. You're not always going to have the ability to negotiate the value-based arrangement that you want, but you should be thinking about what you think is going to work best for you as you go forward. These, as a reminder, are the elements of the value equation: outcomes, costs, risks, and scale. And the questions that you'll answer, and the first one is probably the most important in the short term, is which value-based payment methodology is appropriate for your organization? What areas of the equation do you intend to impact through your readiness work? What are the things that you need to budget for as a result of those? We'll ask you to think about how you would go about predicting your performance without having to go into data and start establishing baselines. What would the process that you would be to do that? What would the results that you would hope to achieve would do that? And then what are the options, what are the barriers and options within your organizations to address those barriers? We'd like to work with you, and we're going to talk about how we're going to spend some time one-on-one with you in getting you ready to make this very brief presentation. We really hope that this doesn't take more than an hour or two of the team's time to come together, discuss, and put together a very brief presentation on. But I think where we want to make sure you are in your discussion as soon as possible is around the value-based, this first question, the value-based methodology. Let me jump ahead real quick. I want to talk about how we're going to help you, reach this goal. We want to schedule individual time with you, about 30 minutes, to talk to one of the three of us, or there might be more than one of us on the call, about the current value-based scenarios that you face. If there's an existing payment methodology that you're evaluating, we want to help you work with that. If there isn't an existing value-based payment methodology that you're evaluating, we'd like to work with you to think about some of the value-based models that might work best for you. And then this is going to help you answer the rest of the questions in the homework assignment leading up to the 5-minute final presentation that say, okay, given what you've told us about the model that you'll be looking at, given your concerns about performing financially under that model, the infrastructure you feel you need, the capital investments needed to, to be addressed, here's the best way essentially to move forward. As I mentioned, we'd like in that conversation to really begin with an understanding of either what you're facing or what you'd like to see in value-based reimbursement. So please think about that before signing up for one of the 30-minute time slots. These time slots are coming up relatively soon, so please don't put this off. We really want to have an opportunity to engage with each and every one of you individually on this. And the outcome, I'm sorry, I'm jumping a little bit out of order here. The outcome will be a very brief 5-minute presentation using the attached template, which you'll receive from AJ, and that will be presented at our final session, which I believe is December 5th, for you to kind of share where you are, how you're addressing the challenges that you're facing, and what you think the future for your organization under value-based reimbursement ultimately looks like. So once again, these are the questions that we're asking you to address. You'll see that there's a template of slides that really help guide you to creating a very concise presentation to make this work. Because we want to try to create some accountability, we want you to realize that we've already gone ahead and scheduled. We drew out of a hat, and the 12 organizations will be presenting in the order you see here on the 5th. We know some of you are associations, and so when we speak with you in the 30-minute sessions, we'll help address how we might make the exercise as appropriate as possible for you as well. But we will get you teed up on the 5th to present in this order as we wrap up our overall sessions. We already talked about the homework. So with that, I want to see if anyone has any questions or comments about either the content we've talked through today, the homework assignment, or the final project. Okay, I'm not hearing any questions or comments. I'll intend to hang on the line for a few more minutes if folks do decide that they want to ask questions. Otherwise, AJ will be following up with you with all of the information that we talked about, how to sign up for your 30-minute session, where to answer your homework questions, and how to engage with us on the final project. And with that, we will see you folks at the same time 2 weeks from today. Thank you very much.